Welcome to this Q&A, Dr. Izquierdo. I'm so happy that you are here with us today to help us clarify some of the questions that we have been receiving about the beta weight and the implantation bleeding.
Hi, Andrea. Thank you so much for the invitation. Like always, I'm very glad to be here with you and be able to answer some questions for our patients that might have some concerns about these topics.
So one of the most common questions I get during the 2-week wait has to do with the fact that patients are very anxious during that time. They're looking for signs of symptoms of pregnancy. And if there is a bleed, a lot of times they start thinking that it might be a miscarriage. And they get really anxious during that time. But sometimes I say it can be implantation bleeding. So how can a patient differentiate between what is menstruation, what is miscarriage bleeding, or implantation bleeding during this time?
The most important thing to understand is that in order to miscarriage, you need to be pregnant.
Okay.
Therefore, if you haven't had a positive pregnancy test, you cannot be miscarriaging. You didn't implantate. So that's the first thing to clarify, because a lot of our patients come and tell me, Hector, I just miscarried, and I'm okay, wait a second, 7 days after you transfer, you have a miscarriage. The bleeding might have at this moment 2 causes. So how does it work? Normally when a woman gets pregnant, an endometrial lining is prepared, immersion full of blood, and it comes a baby and it starts producing HCG. This HCG goes to the endometrial lining as support that it keeps on growing and stays big. If there's no implantation, if there's no embryo coming there and releasing HCG, this endometrial lining starts getting old and might produce some bleeding. At the end, in all cases, it's different. Why? Because we don't need the support from the HCG to stimulate the production of estrogens and progesterone, because we substitute them. Patients who have an IVF cycle, if they have a CT, most of them they are getting estrogens and progesterone substituted. Therefore, natural is not there anymore. And in the other case, when you do an IVF and you make a fresh transfer, you've been receiving so high dosages of FSH that has increased so much your estrogen and progesterone level that you're no longer in the normal rate. Then, how can I differentiate? What should I expect? My first recommendation to every woman is not to think about it at all. Trying to figure out a way to find if I'm pregnant or not at the beginning of these 14 days makes no sense. The most important thing has no positive or negative effect in the pregnancy. Therefore, as we always help to give us a, if it's positive effect, it's something new that I can change and potentiate, wonderful. Or otherwise, at this moment, as far as difficult as it might be, is try to not think about it and relax. First point. Second thing, when do I know I am pregnant? Easy, be the HCG. Is the pregnancy hormone positive? There is a pregnant woman. There is no pregnancy hormone, there is a pregnancy. End of story. What are the differences in between an implantation and menstruation or a miscarriage bleeding? So let's go to the topic. Let's say the patient has already gotten a positive pregnancy test and she knows she's at least with an embryo that's trying to attach and producing HCG. Okay? Therefore, if it is this way, the HCG that the embryo produces makes that the endometrial lining start producing more and more vessels. Why? Because I was in my patients, there is not a strict connection in between vessels from the mother and vessels for the baby. What it happens are 2 things. The baby produces vessels that go to the placenta and go really near to the uterus. The other way around, the woman is not capable to produce vessels that do the same, like the placenta. what she produces is lacunes. She makes a
Okay.
lot of vessels that release blood in a lacune, so the baby can take from that what it needs and give back what it doesn't need. That needed to be solved because if there was a lot of pressure in this near to the baby, the transport of oxygen, sugar, and everything would be more difficult for the baby. Therefore, it needs to be that from lacune to vessels. Okay? So, if I'm having implantation, it might be normal that there's some bleeding. Why? As I told you, HCG makes more production of vessels and production of these lacunes. And if it happens that it will be a lacune produced besides the embryo, not in the place where the embryo is produced in the placenta, then this blood may come out and generate some spotting or bleeding itself. What's the difference? A pregnant woman has an anticoagulatory factor in the placenta. Some factors that reduces the blood clotting system nearby. So this bleeding tends to be really fat, really light, really vibrant. That's not going to coagulate at the beginning. Afterwards, it's going to be more brown because once the blood gets in contact with the vagina, all the bacteria that are there change this blood, oxidate it, and you see this brown discharge that you produce.
Yeah. So in terms, the implantation bleeding will be different because it's lighter and the amount of blood is also not as much.
Yeah. It's like when you cut yourself.
Okay.
So vivid and so light it is.
Yeah, but it doesn't happen every time, does it? Or in every woman?
No, it doesn't happen in every woman. But what I need to do and we need to say is that it's more common in women that go to IVF.
Okay.
This process is not as natural as the natural process. And one of the things is this: women with IVF have lighter increased risk from a miscarriage and as well from bleedings in the first trimester, which doesn't mean that this woman is going to miscarriage, but it can happen.
So is there a way of confirming if that bleed is from implantation or not? Or
yes, but then we go to the topic again. Does it make a change?
yeah.
Can I improve something? Yes or no? But I always say to my patients when they say, I want to make an ultrasound, I want to see that everything's happening, I say, okay, let's think it rationally. What do we need? Then, if we are waiting for pregnancy to implantate, we need a uterus that's really relaxed and in good conditions to accept this baby. Every time we make an ultrasound, we do three things against it. First of them, when you stimulate the womb with an ultrasound, with a vaginal sound, what you do is provide a contraction from the uterus. That's going to be negative for the embryo in two directions. First of them, the contraction itself, and second of them, if you remember a bit of the anatomy, you remember that we have the spiral arteries. Well, we know you women have spiral arteries in the uterus womb, and when the contraction of the uterus happens, these arteries are going to be closed. Therefore, the contraction of the uterus decreases the bloodstream that goes to the embryo. Therefore, if it's not needed, then try not to do it. Second thing, when you put an ultrasound in the vagina, you put near to the cervix bacteria that shouldn't be strictly there. This bacteria could go to the uterus, produce an inflammatory reaction that can lead to miscarriage. And the third thing is a very popular Latin say that we always have, from very old, primum non nocere. First of all, not damaging.
Yeah.
Am I going to have a consequence from this ultrasound? No.
Yeah.
It's not going to bring us any consequence, therefore, we shouldn't do it. What we should do is we can make a beta HCG test and see if 2 days after that it increases. If we see an improper increasement of the HCG, then we're good to go.
Yeah.
More than that, sorry, there's nothing we can do.
Yeah, so there are no signs or symptoms that we can look for. It's just a matter of being really patient during these 2 weeks to wait for the pregnancy test. And this beta test, it will measure, like you said, the HCG hormone that is being produced. What is a good number, or is there a good number that patients should aim for?
That's also very tricky and dangerous, because once you give patients numbers, they get really obsessed with these numbers, and that's not that good. What we need to see is that a beta HCG that increases is good. All of that is false. So if we have a woman who has a beta HCG from 20, and we control 2 days later, it's 14, we're happy. It's going, it's going properly. What I would like to say in this direction is which beta HCG I need to control and which not. What I would say is every beta HCG above 150, I will control, because I will be very happy and say, okay, it's working, it's going in the good direction, let's again. If they are in between 50 and 150, I would like to control them in about a week.
Okay.
And if they are under 50, I would like to control them in 2 days.
Okay, so it's more important to see if the number increases and doubles than the first number by itself.
But just in the case of patients who have beta HCG under 150.
Okay.
The rest of them, I don't care.
Okay.
But they're pregnant. End of the story.
And if the numbers are below what is expected, is there anything that women should do, or is just coping with the loss of that cycle, and just start thinking about maybe what could be done differently for the next cycle?
The first thing, one step after the other.
Yeah.
If the beta HCG is not as good as we want it, but still positive, then making a consult. And just when you confirm that it's not increasing or decreasing, then not making any further steps. Keep with the plan. I believe, and I really want to believe, that all professional healthcare givers that are involved in this process are aware what they should do before the transfer, and that everything that's needed for this transfer to work is done before. Before, just keep with the treatment. 2 important things I like to say, but something I always do in this type of patients. If I have a positive pregnancy test and it's increasingly properly, but bleeding is always still there, what I always do is give my patients a bit of magnesium, high dosage of that, because if you remember uterus, the uterus one has muscles. This smooth muscle reacts to magnesium with relaxing, and a relaxation from the wound may allow the baby to have better circulation. And one thing that we also can do is increasing the dosage of progesterone to allow this communication between placenta and uterus to work a bit better. But more than that, there's not much that we can do. And a third factor I always like to speak about is how I feel and how my body turns these feelings into hormones and neurotransmitters. And therefore, if I'm feeling anxious, if I'm feeling fear, if I'm feeling wrong, I release a lot of hormones and neurotransmitters in our body. One of those cortisols, other of them adrenaline, other of those, these neurotransmitters and these hormones may as well reduce the blood storm in your womb. Adrenaline makes that your body redistributes the blood in more important parts, because your body thinks you need to hurry and run away from a threat.
Okay.
The womb is, not one of those important organs that need to be good supply under stress. Therefore, if you stress yourself, your body will naturally try to reduce the bloodstream to the womb and affect the pregnancy. Therefore, try to go to this happy place where you feel more comfortable, and therefore you'll be happy in your pregnancy.
So it can be quite challenging, can't it, for patients, because that time between transfer and pregnancy test is one of the most emotionally challenging times. Patients are thinking, Is it going to work? Is it not going to work? Maybe this is my last attempt. What tips would you give to patients to remain calm and maybe distract themselves from thinking about all the what ifs that can happen?
What I always do is tell my patients, or what I try to talk with my patients before we start the whole process, is I always need within the therapy that the patient finds a way to distract herself of this whole process. That she is always back in her life, back in her things. And there are many things that patients do differently. There are some patients that do meditation, there are some patients that do yoga, there are some patients that look Pilates, there are some patients that go to make walks, there are some patients that like to be are surrounded from people. I think we all know what to do when we want to be settled down and calm. And then I focus my patients on that direction. I tell them we need to work on this scenario and this situation to make you feel better. So you invest a lot of time of it while you're waiting, because it helps you to go down, back, and increase the chances of this all succeeding. It's my personal belief. Some doctors may be against my opinion.
No, I agree. I think it's important for patients to figure out what works for them, because there isn't one solution that works for everyone. But if we are more in check with our emotions, if we are distracted, if we find other things that we enjoy doing in life, then we're more able to make decisions about our health as well, and about the fertility process as well.
Insight and awareness of yourself is something very, very important in this process.
Dr. Izquierdo, thank you so much for answering our questions. It's always a pleasure to have you here. And I know if there's any more questions, we will schedule another Q&A as well. Thank you so much. Have a nice day.
You do as well. Always a pleasure. Bye-bye.